the moderators. Sangamitra.
Sir.
Yeah, you can introduce both the moderators and start the session.
Good
Yes.
evening, Hetal sir.
Good evening.
Deepak
How
here.
are you?
Fine, sir. Thank
Dr.
you.
Deepak, how are you?
Good, sir.
Good evening all. I welcome Dr. Deepak K sir and Dr. Arun V sir for today's session on Journal Club. We have some interesting topics to discuss today, and I believe Dr. Priyadarshini S will go ahead with the first topic of hip fracture in pain management, especially focusing on the posterior aspect of the hip joint. So, Dr. Priyadarshini, are you ready?
Yes, ma'am.
Okay, please go ahead.
Yes, ma'am. So, good evening to all the respected faculties and colleagues present here. I am Dr. Priyadarshini S, a fellow from GANGA Hospitals, Coimbatore. And today I'm here to present on a topic of hip fracture pain management, mainly emphasizing on the posterior hip innovation. So the title of the article is Posterior Hip Pericapsular Block with Pericapsular Nerve Group Block for Hip Fracture, which is a case series which got published in BMC Anesthesiology in October 2024. And the article was conducted in the Department of Anesthesiology and Joint Surgery at Aerospace General Hospital at China by the authors of Duan et al. So, what is the main background text for the article is like hip fractures are common in elderly patients, which carry significant morbidity and mortality. And nearly the mortality rate is 1 year mortality rate is 15.9% in women and 38% in men. And nearly 50% of the patients lose the ability to live independently. And all the blocks, regional anesthetic block or analgesic block, what we are providing mainly target on the anterior hip capsule, like what we usually give is facial iliaca compartment block or PENG block, so which leaves behind the posterior capsule. So this article mainly emphasizes on the posterior capsular pain and what are the ways to block it. So coming to hip joint innovation, so hip joint, it is a ball and socket type of joint which is formed between the acetabulum and the head of femur, and the mainly the pain generating structures. It depends upon the pathology of the pathology. So mainly if it is an osteoarthritis, it usually it is localized to the capsule, and if it is a traumatic case, the nociceptors or pain generating structures may be osteotome, capsule if there are capsular disruption, along with the myotome if there is some muscle inflammation because of trauma. So we are mainly targeting the pain generating structures and depending upon the surgery or what is the pathology. So here the main pain generating structures or nociceptors are located in the anterior capsule, which is supplied by the lumbar plexus, like branches of lumbar plexus, and posterior capsule, which is supplied by the branches of sacral plexus. So, what are the types of sensory receptors which are majorly located? Are either it is mechanoreceptors in the form of Ruffini, Pacinian, and Golgi corpuscles, and nociceptors in free nerve endings. So these nociceptors and mechanoreceptors are located when we are taking nociceptors are more in the anterior capsule, which is in the superior central quadrant, and then which decreases towards medial and lateral side on the superior most aspect. When compared to like a posterior capsule, nociceptors are in a less quantity when compared to the anterior capsule, and in supromedial quadrant of the posterior capsule, nociceptors are really negligible. But when compared to nociceptors, mechanoreceptors are more in the supralateral quadrant of the anterior and posterior capsule, which then decreases in the trend towards the supracentral quadrant of the anterior and posterior capsule. And the mechanoreceptors are less in the inframedial quadrant of the anterior capsule and supramedial quadrant of the posterior capsule. So since nociceptors are more in the anterior capsule, the anterior capsule are more blocks we are targeting on the anterior capsule only. But posterior capsular nociceptors are usually they are silent nociceptors and their mechanoreceptors are more and which play a main role in proprioception and joint sensation. And these nociceptors are usually get activated in chronic hip pain or in inoperable hip fractures, where the nociceptors become activated, and in that type of cases where the posterior hip pericapsular neurolysis play a role in chronic hip pain. So that was a study where anterior hip capsular neurolysis has been done. Even the patient had complaint of pain. And so that after posterior hip pericapsular neurolysis, the NRS or VAS score reduced to 1 less than 4. So posterior hip capsular pain is more prominent in inoperable hip fractures and in case of dysplasia like that. So when coming to the anatomic regions, like innervation of anatomic regions of the hip joint, so mostly the anterior capsule, it is supplied by the femoral nerve, obturator nerve, and accessory obturator nerve. In this, like femoral nerve almost supply all the quadrants, and obturator nerve supplies the supromedial and inframedial quadrant, and the lower articular branches supplies the infralateral quadrant. When taking accessory obturator nerve, it supplies the supromedial and inframedial quadrant. So out of the all the anterior capsular branches, so compared to femoral nerve, obturator the frequency of supply of nerves like branches to the anterior capsule, obturator nerve is more than the femoral nerve. But when coming to posterior capsule, nerve to quadratus femoris provides a more consistent nerve supply to the posterior capsule than all other nerves, and with less frequency coming to inferior gluteal nerve, which is less than 10%. So this is a schematic diagram showing the quadrants of the hip joint and the nerve supplying it. So femoral nerve, almost all the quadrants, but mostly on the lateral quadrant, supralateral and infralateral quadrant. Obturator nerve and accessory obturator nerve takes care of the medial quadrant. Whereas coming to the posterior capsule, sciatic nerve and superior gluteal nerve covers the superior quadrant, and nerve to quadratus femoris covers the inferior, and inferior gluteal nerve, which is present in only 10% of cases, like articular branches in only 10%. So they supply the infralateral quadrant. So what is the main aim of the study is like all the anterior hip capsule block what we have given has been an established target of neural block. So this mainly targets the obturator nerve and femoral nerve. So which has further led to the investigation of like what are the other sources of hip capsule innervation. So now coming to the posterior hip capsule, there are very much less attention, even though there are literature supporting their innervation from the superior gluteal, inferior gluteal, sciatic, and nerve to quadratus femoris. So these are the articles like which emphasis on the innervation of hip joint, mainly on the both the anterior and posterior capsule, and they explain about the articular branches like the when we take femoral nerve, the femoral nerve there are high articular branches and low articular branches. So compared to obturator nerve has about 98% supply to the anterior hip capsule, but femoral nerve has only 96%. So obturator nerve has more consistent nerve supply to the anterior capsule than the femoral nerve. So when taking to a posterior capsule nerve to quadratus femoris, they have found that in all these studies there is 100% supply to the posterior capsule by the nerve to quadratus femoris than all other nerves. And these two articles mainly emphasize on only the hip joint innervation. And these are the two articles which has been recently published, which they had given two new blocks. Like one is a deep posterior gluteal compartment block for regional anesthesia of the posterior hip. This block they have done as a pilot study. In this block, actually, there was a cadaveric study followed by two case reports. So, in a cadaveric study, they have given a 20 ml of dye and they are finding out which all the nerves getting blocked. So, in the cadaveric study, the superior gluteal nerve, inferior gluteal nerve, sciatic nerve, and nerve to quadratus femoris, even the posterior cutaneous nerve of thigh is getting like it is getting stained. And in the case reports also there were involvement of sciatic nerve and posterior cutaneous nerve of thigh. But what was the difference between this deep posterior gluteal compartment block and the block what I am going to describe, like posterior hip pericapsular block? What they were discussing is that in the deep posterior gluteal compartment block, the local anesthetic is injected over the posterior acetabulum rim. Whereas here in our study, like in posterior hip pericapsular block, they are giving the drug between the piriformis and ischiofemoral ligament, not over the posterior acetabular rim, so that sciatic nerve getting spared. And there is another one article which is a modified hip pericapsular nerve block, which is a combined PENG block with deep posterior gluteal compartment block, which was also published in 2025. That also like mainly emphasis when we give both anterior PENG and posterior PENG, the patients having better VAS score, but they didn't do but they didn't have a control group to compare between the PENG block or versus posterior hip pericapsular block or versus the combined block. So we cannot relay like whether the only the anterior PENG block provided the better pain relief or the combined block provided better pain relief. So the main development of this study is to block the nerve supplying the posterior capsule, mainly emphasizing on the nerve to quadratus femoris, superior and inferior gluteal nerve. So they have found that when we combine the PENG block with a PHP block, it provides comprehensive analgesia. So it is a case series which consists of 5 patients with a mean age of 68 years, an average BMI of 23, and out of that 80%, like 4% was diagnosed with neck or femur fracture, and 20% of patient with like 1% is an IT femur fracture. So it is a case series which was done over a period of 3 months from December 2023 to February 2024. And all ethic committee approval and informed consent, everything has been done. And like post intervention, they are assessing the patient for 48 hours. So inclusion criteria was unilateral hip fracture patients from trauma without any contraindications to regional anesthesia block, and intervention they are performing the ultrasound guided PENG block with posterior hip pericapsular block before they are proceeding with total hip arthroplasty. So in the outcome, they are mainly measuring the primary outcome as NRS pain score and hip motor function, and secondary outcome is opioid usage and complications. So what was the technique is they followed us before the block, they have given intravenous pericoxib and betamethasone, followed by they are providing PENG block with PHPB. After that, they are inducing the case under general anesthesia, and at the end of the surgery to overcome the pain from the dermatomes. They are giving incisional subcutaneous infiltration of 10 ml of 0.25 ropivacaine. So in the for pen group block, they are proceeding the patient in supine position using a convex probe transversely at anterior superior iliac spine. So they are giving a local anesthetic of volume of 15 ml of 0.25 ropivacaine between the psoas tendon and iliopubic eminence, which mainly targets the femoral nerve, obturator nerve, and accessory obturator nerve. So for posterior hip pericapsular block, it is usually performed like 5 minutes after ping block and in the lateral position with the affected side up and the healthy side is slightly flexed, and they are using low frequency convex probe vertically at the midpoint of line between the posterior iliac spine to greater trochanter, and they are performing in plane, and the drug is deposited between the piriformis and ischiofemoral ligament to mainly target the sensory nerves, nerve to quadratus femoris, superior gluteal nerve, and inferior gluteal nerve. Here also they are using 15 ml of 0.25 ropivacaine. So after this block, they are mainly assessing the NRS pain score. So at rest and maximum during limb movements. So they are measuring the NRS score pre-block, 30 minutes post-block, 6 hours, 12 hours, 24 hours, and 48 hours. And apart from the NRS pain score, they are also evaluating the maximum voluntary angle of hip flexion, abduction, adduction, and knee flexion, and followed by the quadriceps muscle strength, which is measured at 24 hours and 48 hours post-operatively. So in post-operative analgesia protocol, they are following like oral celecoxib 200 mg per day, and patient control intravenous analgesia pump. They are using oxycodone, and it was also mentioned like there was no continuous infusion, but boluses doses of 5 ml with lockout time interval of 15 minutes, and the rescue remedy is activated only if NRS score is more than 3 for more than 30 minutes. And for rescue remedy, they are following intravenous hydromorphone 0.1 mg per kg. So what were their results is the NRS score, it reduced from 3, like NRS score was 3 at rest. From 3 it has reduced to 0, 24, it has reduced to 0 in 48 hours. But when we take the NRS maximus score, like the maximum NRS score at the hip motion, either it can be flexion, adduction, or abduction, it was 8. And after the post-operatively, like at 48 hours, it has reduced to 1. So when coming to opioid consumption, so in the first 24 hours, out of the 5 patients, only 2 patients required oxycodone, and they have activated the PCA pump twice, and they have utilized about 4 mg of oxycodone, and none of the patient required analgesic rescue remedy in the first 24 hours, and like in the first 48 hours they didn't require any rescue remedy except for the 2 patients who have taken PCA pump twice in the first 24 hours. So what were their results is all the 5 patients could autonomously perform hip flexion, abduction, and adduction, and knee flexion within 24 hours post-operatively, and there were no signs of movement disorders or quadriceps muscle weakness. And also there was no statistical difference in the hip range of motion when compared to the healthy side. So the safety profile is there was no severe post-operative complications like wound infections, hematoma formation, or nerve damage. So this is the motor function outcome. So they have done the motor function test on the healthy side, and they are comparing with the affected side 24 hours, 48 hours post-operatively, and they didn't find much difference in the voluntary angle of movement. So coming to discussion part, so maybe it is a novel technique which is targeting the posterior hip capsule. It has reduced the opioid consumption as such. But when coming to the clinical implication as that is really it provides the ERAS, like it really follows ERAS protocol is questionable because they have many limitations in assessing the motor block related to sciatic nerve that I'll like mention in the study limitation. So of course, because they have combined PENG block with PHPB block, obviously the opioid sparing is less because the pain score is less, the requirement of opioid is less, so that the patients may not land up in any perioperative complications. But some like randomized controls trials should be, it is needed to validate their efficacy and determine the optimal dosing and the safety profile. So what was the study limitation is that, so mainly the study is a case series design and that too in a short period of time, and there was no control group for a direct comparison between the pain relief is because of PENG or the pain relief is because of the posterior hip pericapsular block or the pain relief is because of the combined block. So they should have kept three groups. First for PENG, next for PHBB, and next for PENG with posterior capsule, so that we can say like yes, posterior hip pericapsular block also works out. Like even without PENG, how much is the percentage of patient complaining of pain with only PHBB block? So that was missing. And next is small sample size so that we cannot generalize it. And the optimal concentration and volume of local anesthetic, like much studies are required to find out what is the exact concentration of the local anesthetic and volume of local anesthetic required, so that motor sparing effect will be like that it doesn't involve the sciatic nerve, so that the mobility gets affected. So and they have taken ropivacaine as the like study drug. So the ropivacaine already have a motor sparing effect, so even if it sciatic nerve gets blocked because of its motor sparing effect also, we could have missed that. And we cannot also confirm like whether 15 ml ropivacaine affected the sciatic nerve because in the study totally they have not assessed motor block in serial intervals as they assessed the NRS score. So the NRS score was assessed at 3 hours, 6 hours, 12 hours, 24 hours, like that. But the motor blockade or all the hip motions, flexion, adduction, abduction, everything was evaluated at 24-hour and 48 hours only. So at that time, either the effect of drug could have already gone, so that they could have missed the actually the sciatic nerve may get involved, but since they have done the assessment only at 24 hours, they are saying like sciatic nerve is not involved, but sciatic nerve might have involved. And sensory, and we couldn't say like like there is sciatic nerve involvement pre-operatively also, because in all the like most in hip fractures there can be sciatic nerve involvement, there can be sciatic nerve injury also, and they are going with the posterolateral approach of total hip arthroplasty. In that case also there can be sciatic nerve injury, so we cannot say the sciatic nerve got injured pre-operatively or post-operatively. So they should have done the sensory and motor assessment of the sciatic nerve both pre-operatively and immediate post-operatively also, and so that we can differentiate it like sciatic nerve is not involved like by our block. And the pain evaluation they have mentioned as NRS maximum score, that was not specifically done at exact site of, so where does the patient complaint of pain, whether it is an anterior hip joint pain or the posterior hip joint pain, and exactly also the motion at what point. So either at hip flexion the patient is complaining of pain or hip adduction, abduction, so that was not also mentioned. properly, like correctly, and the time to first rescue analgesia was also not evaluated, which like determines the effective duration of block. And regarding opioid consumption, they have mentioned as PCIA pump has been used, but they are also mentioned it as there is a not a continuous infusion is not used and only bolus doses. They have not mentioned whether at what time the patient exactly activated and what is the time interval between the two activation of time pump and the time between and it is also a waste of resources at so it was mentioned like in rescue remedy NRS more than 3 they have given IV hydromorphine, but when coming to PCA pump they have not mentioned at what pain score they have activated the PCA pump. So without continuous infusion, why they have kept PCA pump? This was all questionable in the study. And
Ritesh sir, hey yaar, he must have seen that I didn't join. He watches all this thing a lot.
Dr. Priyadarshini, please continue. I muted them.
so, as a conclusion from this study, ultrasound guided pen block with posterior hip pericapsular block, yes, they provide better perioperative analgesia for hip fracture, but sciatic nerve involvement needs to be evaluated in further studies because in the cadaveric study, which has been done before, also have emphasis that even 20 ml of drug has blocked the sciatic nerve, posterior cutaneous nerve of thigh. And when sciatic nerve involvement is there, almost the mobility will get affected and the main goal of ERAS protocol is getting affected. Yes, ma'am, that's it. Thank you.
Thank you so much. Deepak sir, shall we continue with next topic or shall we have the
I
question
think
and
we can
session now?
continue, madam. We can take the questions later.
Deepak, shall we have it now? Because all three articles are completely different.
Different topics, yes.
Okay, that should also be good. Yeah.
Right.
In that case, Dr. Priya, so it was a nice presentation. So you have covered most of the topics which are things that are discussed in the topic. But tell me, how did they position these patients? Isn't it little odd? What is your thought on that?
Actually, they have positioned the patient in the lateral position only, sir. But what they have mentioned is that, so in previous like deep posterior gluteal compartment study, they required hip flexion of 90 degree and knee flexion of 90 degree. But in this article, they have mentioned we did not require hip flexion of 90 degree, even 10 to 20 degree of hip flexion with that, even without much of hip flexion, we are able to visualize the structures.
So you mean to say that they have given all these blocks in lateral position and then made them supine to give
Yes, sir.
general anesthesia? Is that what it is?
Yes,
They have
sir.
not
It
really
was,
specified how they have given the peng block.
yes, so
Is it
pen
in
block
the
was given
supine
in
position or lateral position?
No.
They have not mentioned.
No.
So-
I think both Priya, you also have to read patients and the pericapsular group. They have specifically said that the LMA was given general anesthesia after peng block combined with PHB.
PHP block, yes, sir.
Correct.
Okay. So the question is whether they blocked both of them laterally. No.
Yeah,
Peng was all
that was
given
the
in
question.
supine. No,
Yes.
in supine position.
No, it is given in supine position. So
Yeah.
it is technically this block is going to be difficult.
Yes, sir.
Yeah. And majority of the time, so where will the incision be when they put capsular incision?
So usually if they are going for an anterolateral approach, the incision will be mostly on the anterior capsule, sir.
Antro?
No, is it?
Anterolateral. For
So
hip
in
surgery.
in this study, they have taken posterolateral approach, sir.
Correct. Usually that is the usual approach, isn't it?
Yes, sir.
So,
That is the standard approach, isn't it? Posterolateral approach to the hip.
Yes, sir.
so where will the spikes be? So when they're retracting, all that the instrumentation that they're going to do will be towards the sciatic nerve if they're not careful. And it involves cutting off all the muscles in the area which has been bathed in the local anesthetic.
Yes, sir.
Okay. Yeah, just this thing. Look, when you read the article, you realize that they have done all the blocks under general anesthesia.
Yes, sir.
All peng and supine, and then lateral, and then this thing, your posterior blocks.
Yes, sir.
Okay. And also, uh, I would not go into the comments in terms of, yes, it's only about 5 patients. So it is a case series. So
5
those,
patients and another had only 2 patients. So other article which was there.
yeah. So it's only a case series. So you have to accept it as a case series. Those are not drawbacks. Those are actually just innovative procedures being discussed.
Yes, sir.
So whether what you need to tell when you do a journal club is, why did you actually choose this article? You tell me, why did you choose it?
Actually, always it is not mandatory that we have to cover posterior hip innervation for all the hip surgeries, sir.
No, then why did you choose this article? Because it does exactly that, isn't it? Posterior hip innervation.
Yes, sir.
No, I just simple question. Why did you choose this article? Just because it's a new technique, isn't it? It's not a question of going into an RCT or anything. You're just describing a new procedure and the reasoning for that new procedure.
Yes, sir.
Yes or no?
Yes, sir.
Yeah. So we take it as that only. Don't when you criticize an article, you should be looking at why did you choose it in the first place. Yes, this is an option which is available. Cons and limitations are there. As a case series, it always will have limitations which you can't deal with.
Yes,
The
sir.
question is now, what else could it have blocked? That you covered a little bit. What was the concentration they give, and how much of that will cover the sciatic, and how much of motor blockade will you see? When you say that it is not, you should not be using this for ERAS, and you may have a sciatic block. What is the concentration of the drug they used?
So they have used 0.25% ropivacaine, sir.
How much of motor blockade will 0.25 give you, even if it goes on sciatic? Hmm? Will it go? Will it give?
Yes, sir. 0.25% may.
Motor blockade. It's unlikely to unlikely to give you sciatic motor blockade, no? At that level, at subgluteal level.
It's going to be a thicker nerve there, and it is little away. It is
It-
not exactly on the structure. As long as you're more lateral rather than towards the sciatic, probably the drug which goes towards that side is limited. Though the cadaveric study in their this thing showed some amount of methylene blue staining on the sciatic, cadaveric studies that they have done.
Look, methylene blue staining per se does not tell you that you'll have motor blockade. No?
Correct.
You also are dependent on concentration of the drug which goes on to the nerve. So the concentration is going to be much lower. And the other thing which you did comment upon is their use of a PCA. Not every PCA has a baseline infusion. And if you have a baseline infusion, that itself, the reason for putting a PCA is you lost the reason for putting a PCA. A PCA is just a patient activated. So if you put a baseline infusion, which you said they did not put, that just goes against use of a PCA. If all patients had a baseline infusion, how would you know that anybody actually needed an opioid?
Yes, sir. Hmm.
So just you need to think why they actually did it. There might be a good reason for doing it, which is actually that's how you would look at opioid requirement in the post-operative period on giving a patient a PCA. And a PCA does not get activated based on the NRS scoring. A PCA gets activated by the patient, whoever feels like whatever the pain is at that moment. So asking for an NRS scoring at what level, when did the patient activate a PCA, is again something which will never come up in a study, which will never be this thing. You just look at a 24-hour opioid consumption by a patient to say that they were in pain or they were not in pain.
So another drawback or whatever suggestions is, will you use this block as a sole block for post-operative pain and a hip surgery?
No, sir.
What is missing here?
So mainly the anterior, like when we give posterior hip pericapsular block.
Suppose if you have given PENG block also along with this PHPB, what is getting missed?
The dermatomal, the cutaneous innervation is getting missed.
Cutaneous innervation, where the actual incision is going to be, that will be missed.
Yes, sir.
Okay. So
And
you
they
need to
covered
block.
that?
How did they cover it?
So they have covered it with the incisional infiltration, sir.
Infiltration. Yeah. So if you want to add some other block, what will that be?
Lateral femoral cutaneous nerves.
Is something which the incision pain can be blocked more effectively with a lateral femoral cutaneous nerve.
Yes, sir.
I think, shall we go off to the next one? Because there are 3 of them, no?
Yes, please. Yes, please. Thank you. Thank you, Priya.
Thank you. Thank you, Priya.
Thank you, sir. Thank you, sir.
Yeah.
Good evening, everyone. This is Dr. K. Priyadashni. Today, my journal club topic will be on a new percutaneous device which enables both local anesthetic delivery and electrical nerve stimulation of peripheral nerves for pain for acute pain following orthopedic surgery. So it is an initial feasibility technical report, and it was published in the article of in the Journal of Orthopedic Experience and Innovation in 2025. And these are the following authors. So pain following orthopedic surgical procedures remain underrated due to inadequate analgesic options. The single injection local anesthetic based peripheral nerve blocks have a limited duration of action of less than 24 hours. Whereas the options of prolonging analgesia, like the availability or usage of liposomal bupivacaine or continuous peripheral nerve block catheter, again has a limitation that the duration lasts only for approximately 72 hours. So all the available options to us has a duration of action which outlasts the pain experienced by the patients, which is mostly in weeks and not hours or days. So this led to the discovery of this device, which is an analgesic alternative, which offers percutaneous peripheral nerve stimulation, and it improves the post-surgical analgesia while also decreasing or completely avoiding the opioid requirements without any adverse systemic side effects. And this device is the relay system, which was designed by Gate Science, based in USA. So the relay system, it is a device comprised of a basic catheter over needle to allow ultrasound guided percutaneous insertion and leaving a perineural catheter after simple withdrawal of the internal needle. So through this device, a single injection bolus of local anesthetic can be quickly administered, and following surgery, the catheter may be attached to a portable infusion pump to provide a continuous perineural local anesthetic infusion as well. So this is the device. So the upper part shows the needle, and the lower one is the catheter, and at the end of which there is a pulse generator and a port for injection of local anesthetic. So the device is available in two lengths. One is a short one, which is 7.7 centimeter with a catheter length of 7.3 centimeter, and a long needle with a length of 11.5 and 11.4 centimeter catheter respectively. So this is the design of the catheter, in which the end of the catheter has 3 electrodes, which can be programmed as either the anode or the cathode according to our requirement. And some projections are seen exactly at 4 centimeter from the catheter tip, which can be rotated clockwise or counterclockwise, and these help in anchoring the device without any migration issues. So the device also has an embedded wire and an integral pulse generator, which permits the stimulation of the targeted peripheral nerves for up to a duration of 28 days. And this can be connected to a smartphone application via Bluetooth connection. And this can be operated by the patient themselves, and they can alter their stimulation intensity according to their pain intensity. So the author claims that this is a potentially revolutionary device because it would allow us to do a single injection peripheral nerve block and to provide a continuous local anesthetic infusion, and also perform neuromodulation using a single device, which can be placed in the same amount of time required while performing a single injection peripheral nerve block. So, and also the duration of analgesia is prolonged for up to a duration of about 28 days, and it can be delivered without any disruption of the existing practice patterns. So this is a video which was taken from the streaming platform YouTube, and this describes the design of the device.
System is the first to combine pharmacologic blockade and neuromodulation in one multimodal device. An injection port delivers analgesic to induce primary nerve block. Relay's wireless integrated pulse generator provides neuromodulation via 2 electrodes at the distal end of the lead. There's a second injection port for treatment of breakthrough pain following discharge. Relay fits into existing workflow, and clinical deployment is as simple as performing a single shot block. Prior to surgery, Relay is positioned next to the target nerve and delivers primary nerve block. Surgery proceeds with Relay in place, outside of the surgical field. After surgery, neuromodulation is activated. Following discharge, the patient is in control. Instead of reaching for an opioid pill, the patient adjusts pulse intensity up or down via an app on their smartphone.
So this is how the basic working principle of the device is.
System is the first to combine pharmacologic.
So here they've described a case report in which this device was used. So following a US FDA approval sought under investigational device exemption, prospective registration and local institutional review board approval was obtained, and a 67-year-old ASA1 female was enrolled for the study after obtaining written informed consent. So this patient was posted for right reverse shoulder arthroplasty. With the patient in the supine position, and all standard intraoperative monitors were placed, and oxygen was delivered by face mask. The pulse generator was turned on by pressing a single button, and it was connected via Bluetooth to a mobile device. In this case, an Apple iPhone 16 was used, and a proprietary app called the Gatekeeper, designed by the Gate Science, was used to control the device. So the minimum and maximum currents were set to 0.2 milliamperes and 10 milliamperes. And the right side of the neck was cleansed with chlorhexidine solution, and it was covered with a sterile drape. And procedural sedation with IV midazolam 1 mg and fentanyl 50 mics was administered. And using ultrasound, the target nerves were visualized with a linear transducer in a sterile sleeve. So this is the interscalene block was performed with the patient. The device was advanced posterior to the C5 C6 nerve roots with small boluses of dextrose 5 water via the integrated needle to open the potential space between the roots and the surrounding fascia. So the pulse generator was initially initiated at a current of 0.2 milliampere, and slowly it was increased until the patient perceived a pleasant massage-like feeling over her shoulder. In this case, the current was around 2.2 milliampere for this patient. Then the internal needle was removed and lidocaine 2% with epinephrine 10 ml was injected via the remaining catheter, and accurate catheter tip placement was demonstrated with a decreased cutaneous sensation to cold temperature over the deltoid muscle. And to prolong the duration of analgesia, bupivacaine 0.5% 10 ml was subsequently injected. And then, as we had already described, the catheter has 3 electrodes at the end. So in this case, the distalmost electrode was programmed as the anode and the middle as the cathode, with the proximal electrode being inactive. And the catheter was rotated anti-clockwise, and it was anchored with and the small projections or the tines which was emanating from the catheter helped to anchor the catheter over the skin. So the device was secured with wound closure adhesive and an overlying occlusive dressing. And then local anesthetic infusion with 0.2% ropivacaine was initiated with a portable infusion pump via the catheter. So the infusion rate was 8 ml per hour basal infusion followed by 4 ml bolus dose with a 30-minute lockout period and in a 500 ml reservoir. So the pulse generator was then turned off, and the surgical procedure went through without any complications. General anesthesia was also administered with an inhaled anesthetic combined with nitrous oxide. So immediately after the surgery, in the recovery room, when asked, the patient reported no surgical pain, and the pulse stimulator was immediately turned back on with a current of 2.2 milliamperes, which was initially perceived by the patient as a pleasant sensation. So the lowest current level perceived by this patient during the insertion is always chosen to avoid overstimulation. This is because when the local anesthetic effect is still in place, the patient may not feel when higher levels of current are given. But once the effect goes off, the patient may not be able to differentiate between the pain, which is either due to the surgical procedure or due to the high level of current which is being delivered. So then the patient can increase the current when her peripheral nerve block begins to resolve. So she was discharged home with verbal and written instructions, and the app was downloaded by her to her own phone and was taught how to connect to the pulse generator and adjust the current level. So the day after surgery, the patient's initial single injection nerve block had been resolved, and she experienced a maximum pain score of in an NRS rating of 3 and an average NRS of 1. For the remainder of her local anesthetic infusion, which was continued for a duration of 3 days till POD 3, her NRS score was around 0 to 1. And after which neuromodulation was the exclusive analgesic which was available. And during this time period, her maximum and average pain score was 0.5 and 0 on POD4. So on POD7, the catheter was removed by the patient's caregiver at home itself, and the gentle dressing was applied, and the pulse generator and catheter was discarded. So on POD8, when the patient was again asked regarding her pain, she reported no pain following POD4, and there were no opioid requirements following the surgery. So, in conclusion, this device is it has good feasibility in providing a single ultrasound guided insertion to deliver a local anesthetic for a single injection nerve block and subsequent perineural local anesthetic infusion and up to 28 days of peripheral nerve stimulation. And it can be applied to any peripheral nerve and most surgical procedures of the extremities. Since neuromodulation does not induce any sensory motor or proprioception block, it can be used in lower extremities without increasing the risk of fall, and it can even be used in bilateral procedures where adequate analgesia can be achieved. So, critical appraisal of the article. Abstract was structured and concise. Introduction gave an idea of the study and the device being used. In the case report being described, it explained the procedure well, but images and videos of the procedure or the device which was used could have been added for better understanding of the readers. And the image provided in this article was also an illustrative image, not of the same patient which was described in the case report. These were the references given by the author, and conflicts of interest had been mentioned in the article. And future prospects, it requires further testing of the device in a larger and much more diverse population to assess the efficacy of the device. So, cross references. This is one more neuromodulation system called the Sprint neuromodulation system, which was designed by SPR Therapeutics, again based in USA, used for acute postoperative pain management. So, in this, this is the design of SPR Sprint system. In this, we have an helical structure, which is the needle through which the current will be delivered. The helical structure has a diameter of 0.2 mm. The helix is placed to increase the length of the device, and the second picture on the side describes the device through which can be mounted via a catheter and can be introduced into the patient. And the third one is the external pulse generator, which can be it is battery operated and can be adjusted according to the needs of the patient by the operator. So this is one other device which has been approved by FDA for acute postoperative pain management only in the USA. And it is this system is indicated for use of up to 60 days in the back or extremities for symptomatic relief of chronic pain, post-surgical and post-traumatic acute pain, and symptomatic relief of post-traumatic pain. The Sprint PNS system is not intended to treat pain in the craniofacial region, and it is US FDA Class 2 device approval is obtained. Thank you, sir.
So, Priyadarshini, you missed an important thing. Who is the author of this article?
Sir, authors I had mentioned, sir.
But he was one of the speakers for the last time.
Yes, sir. Sanjay Sinha sir was one of the authors, sir.
He is the one who has designed IPAC, which is routinely used. Any new block for that matter, before we say it is not going to be helpful, we
Yes.
should ponder over it and then decide.
Okay, sir.
So, in this, you said all about female patient, but the picture that was provided is a man with a beard.
Yes, sir. That is what they had given only for illustrative purposes, sir, since they could not share the original pictures. That was also mentioned in the article.
Right. So, how did they place the catheter? That is somewhat, I found it was fascinating. It is rather difficult. So, what was the way in which they secured this device in the first place?
Sir,
most of us, how do you actually give an interscalene block for that matter? How is your probe going to be?
So, probe is going to be in the sagittal orientation, sir.
Routinely?
Mm.
Now, how do you usually place catheter?
So,
you come from medial to lateral or from superior to inferior? Cranial to caudal. How do you actually put a catheter in the interscalene area?
So medial to lateral.
In their article, how did they place it?
Sir, actually, it was not mentioned that clearly, sir, how the catheter was inserted. They had just told that the initial dextrose 5 water was given to open up the space and then the catheter was threaded.
So they have placed the transducer vertical like
Yes.
this, and then they come
You
from
showed the
above.
you showed the
Pic is
picture,
there.
isn't it?
Picture is
Yes.
there, isn't it?
Yes, sir.
Go back to that picture.
System.
See the technique that technique I have not used.
Okay, sir.
So in a short neck, I don't know how you can place this way.
They,
Maybe
they've,
difficult.
they've done an inline with the
Inline.
nerve, inline with the nerve.
Yes.
Nerve.
Mm.
And they have not mentioned how close they were when they actually stimulated the nerve.
Yes.
Have you ever used a PNS for giving interscaling?
Not exactly used, sir, but
See, the current that they have chosen is
yes,
2.2 milliamps.
2.2 milliampere.
If we go
Yes.
close to the nerve, what is it going to be pleasant? Is
No.
my expectation.
Yes, sir. Maybe the distance from the nerve root and where they have placed the device exactly is also not mentioned in
Not
the
mentioned,
article,
correct.
sir. Yes, sir.
Did you find anything unusual about the drug dosages they used?
So the initial dose was 10 ml of 2% lignocaine with adrenaline, sir.
Yeah.
0.5% bupivacaine.
10 ml, 10 ml. Again, 10 ml, 0.5%
10 ml,
bupivacaine.
yes, sir.
Yeah.
So it was a little higher. I mean, the volume was little higher for an interscalene nerve block, sir.
Correct. And that too, they have given at what level?
C5, C6 nerve roots is what they have
The
mentioned.
root,
So.
yes. Yes.
They've given it at that level. Then what did they do?
So then they've given general anesthesia also, sir. Then they've started a baseline infusion also
Of
of ropivacaine, sir, 0.2%.
at what rate?
So 8 ml per hour basal infusion with a 4
About 3
ml
days.
plus
For
dose.
3
Yes,
days
sir.
they have given. Yeah.
So now the question is, without the block wearing off,
Yes, sir.
they've already started a baseline infusion.
Yes, sir.
And then the next day, when the paragraph starts, they queried the patient. The initial single injection resolved earlier that morning. How do you do that?
Now, for 3 days, they have given an infusion, isn't it?
Yes, sir.
Yeah.
No, and they've said the first one resolved the next day morning.
Yes, sir. They have mentioned that the single injection block which was given that resolved the early morning.
Yeah.
Yes, sir. I don't know how they had assessed that.
So, look, when you read an article, you should look at one. It is an innovative idea.
Yes, sir.
They're talking about neuromodulation.
Yes, sir.
Neuromodulation post for acute pain and to prevent chronic pain from developing.
Yes, sir.
So that is one side of the story. The other side of the story is how have they done the process itself? You'll have to look at and query critically.
Yes, sir.
So they have started. Would you normally start an infusion or this thing before your block wears off?
So, usually we don't start, sir. But in this
Especially
study,
if you have used a 0.5% bupivacaine, you would not start.
yes,
At
sir.
least ropivacaine, I would still start.
Yeah. If you're using ropivacaine as such only for analgesia and then this thing, yes.
Yes, sir.
Have you seen any other device in India, which was initially I have seen one, so that's why I'm asking. Have you seen any other device which came similar to this?
No, sir, I have not seen any, sir.
There was one P-stim, which would be put around the ear.
Okay.
They have some points on the ear which can alter the ANS, autonomic nervous system, P-stim.
Okay.
Along with they had one ANSI scope had come. So you would put that and wanted to turn it on. You would keep there for around the ear for about
Yes.
3 days and hope that the pain perception will be less. So
Okay.
probably I didn't like that much, so have not used to that extent. P-stim is something which you can Google and find out.
Yes, sir. Okay, sir.
Any other queries?
No, they have not talked much about how much did they start the stimulation. They've said they've started it at whatever 2.2,
Yes, sir.
but they have not talked anything about how much did the patient increase it to further, depending on their patient's requirement.
No, sir.
Once you start giving local anesthetic, after that, at what levels do the patient actually perceive some relief or a pleasant sensation? They have not mentioned anything about that, have they?
No, sir, they have not mentioned. Actually, this was more descriptive of the device only, sir.
Device, correct.
They have not mentioned those details like the patient experience or how the patient increased the current. All those details have not been mentioned much, sir.
Hmm. So it's just about describing a device. That's about all that has
Yes,
been
sir.
done there.
Yes, sir.
Dr. Anju Gupta has asked, how was the neurostimulation effective with local infusion going on? This is the chat.
So that we will. I don't think we'll be able to assess if the neurostimulation was effective when the infusion was still going on, sir. But they had started immediately after the surgery with the pulse generator with a current of 2.2 milliampere. They have not mentioned regarding that also, sir, how they assessed.
And Anju goes on to ask, what was the ropivacaine concentration used? I think that we have discussed.
0.2% ropivacaine, sir.
Correct. And can you use neurostimulator along with stimulating catheter? I don't think it is a good idea.
Yes.
Because it is very difficult to secure a catheter in the first place if the surgery has to happen following insertion of a catheter in the shoulder region. So invariably it comes out and we may have to secure other time after the surgery. So that also is an issue. Keeping interscalene catheter is slightly more difficult.
Okay, sir.
Any other questions, please?
Shall we move on to the third one then?
Yes, please.
Thank you, sir.
Thank you. Thank you,
Thank
Priyadarshini.
you.
Thank you.
Good evening, sir. Good evening, sir. Myself, Dr.
Good evening. Good evening. Loud and clear. Go
Good
ahead,
evening.
Veena.
I would like to start the journal club by wishing an advanced happy Onam to everybody. So the article which I've selected today for presenting is the topic is the role of supplemental regional blocks on post-operative neurocognitive dysfunction after non-cardiac surgeries, a systemic review and meta-analysis of randomized control trials. So post-operative cognitive dysfunction, the incidence which is seen is around 11 to 51%, and it has been divided to post-operative delirium and delayed neurocognitive recovery. So post-operative delirium, it happens during a first short period of time, and there'll be attention disturbance, disorientation, and memory. Whereas delayed neurocognitive delayed neurocognitive recovery, it happens. It's a new cognitive impairment which happens up to 30 days after a full recovery of consciousness after a surgical procedure. The aim of the meta-analysis was to determine the effect of supplemental regional anesthesial blocks on the incidence of neurocognitive dysfunction in adult patients in major non-cardiac surgeries. The hypothesis which they took was that the incidence of post-operative neurocognitive dysfunction is reduced in patients who have received supplemental regional anesthesia blocks compared to the standard anesthetic care. And there are two outcomes. The primary outcome measures the incidence of post-operative neurocognitive dysfunction within the 30 days. And secondary outcome looks into the severity. Was there any use of antipsychotic medications, and the pain scores, the length of hospital stay, and the mortality. So the study eligibility which they took was based on PICTOS criteria. PICTOS population, they have taken adults who was more than 18 years, who is undergoing non-cardiac surgery. I for intervention, in the interventions which they use were supplemental regional anesthesia blocks, epidurals, peripheral or facial plane blocks. Then comparators, they have made groups in which one group was given either no block or placebo block, and there was a comparison of opioid or non-opioid analgesia also. The outcomes which I have already told the outcomes, that is primary and secondary outcomes were checked, and the timing was within 30 days, and the setting was in an IP setting. So in this meta-analysis, they have covered 26 RCTs from the year 2017 to 2022, and they have taken into consideration 4,414 patients. And in this, 2,251 patients received supplemental regional anesthesia blockade, and 2,163 patients were taken as control group. So the data source which they have taken is from MBase Scopus, Cochrane Central Registers of Control Trial from Jan 2017 to 2022. The data they have taken are the study year, sample size, the type of surgery performed, interventions taken, the outcomes, the anesthesia mode, the type of post-op analgesia given, incidence and severity, scoring systems used, block-related complications, length of hospital stay, and mortality. The risk of bias was assessed based on Cochrane collaboration criteria. The 26 RCTs, there were 8 high risks of bias, 7 had only some concerns, and 9 RCTs had low risk of bias. And it was based on the certainty of evidence was based on GRADE guidelines. So the overview of the included trials, they had included surgical subtypes, hip surgeries, femur surgeries, abdominal surgeries, thoracic surgeries, multi-level spine surgeries, THRs, and there were emergency surgeries, 6 emergency surgeries, and rest were elective surgeries in the RCTs. Then anesthesia modalities, 2 RCTs were looking into neuraxial technique. One trial did not mention any anesthesia modality, and the rest of the anesthesia modality was general anesthesia. And the assessment tools which are most commonly used was confusion assessment method, and for POD, and for delayed neurocognitive recovery, mini mental state examination. So these were the supplemental RA techniques that was used in the various RCTs. Out of the 26 RCTs, 11 had epidural single shot, and the rest had intermittent continuous infusions. There were 2 femoral nerve blocks with intermittent or continuous infusions, 5 paravertebral blocks, 3 single shot facial iliac block, 1 QL intercostal adductor canal, stellate ganglion, lumbar plexus, and lumbosacral plexus block. So the incidence of post-operative cognitive dysfunction in 23 RCTs, that is 4,109 patients, the incidence was found to be 12.4% in the regional anesthesia block group, and the control group 19.6%, which shows that regional anesthesia significantly reduces the incidence of post-operative cognitive dysfunction. Then they had the meta-analysis also has done a subgroup analysis. The aim of that was to evaluate the possibility of association between various patient, technique, surgery related factors and its incidence and its relation to the incidence of postoperative cognitive dysfunction. So the incidence was seen that it was seen that in almost all the secondary subgroup analysis, that is PND's peripheral neural blockade, epidural analgesia, multiple continuous infusions, single shot blocks, perineural blocks, facial plane blocks, and everything, there was a significant decrease in the postoperative cognitive dysfunction when we are using regional anesthesia. So none of the trials analyzed the severity of the postoperative cognitive dysfunction. And there was one trial which had checked for the usage of antipsychotic medications. That is, the patient has developed postoperative cognitive dysfunction and the patient had to use antipsychotic medication. So there was one trial which was showing a significant effect, but still in the regional anesthesia group, the percentage was lower. And the pain score after 24 hours is significant. There is a significant decrease in the pain score in the regional anesthesia group compared to the control group. There is no significance to the intraoperative blood loss, but the length of hospital stay, which it has shown that there is a significant decrease in the length of hospital stay with regional anesthesia techniques. Then there is incidence of postoperative nausea and vomiting is also significantly reduced with regional anesthesia blocks. There was one trial which had reported 30-day all-cause mortality in this meta-analysis. Discussion. Moderate certainty of evidence suggests that regional anesthesia blocks significantly reduce the odds of developing postoperative cognitive dysfunction by almost half compared to the control. Significant prophylactic efficacy of regional anesthesia persisted in reducing the incidence of postoperative cognitive dysfunction and delayed neurocognitive recovery. Various other subgroup analysis based on block-related and surgery-related factors reveal the result of meta-analysis, and all these are consistent across all the subgroup. So the mechanisms by which regional anesthesia acts to reduce the postoperative cognitive dysfunctions are: first one is neuroendocrine mechanism. Usually a neuroendocrine response causes the release of cortisol releasing hormones, and it acts on the hypothalamus pituitary axis. And there is adrenocorticotrophic hormone release and cortisol release, which normally happens, and regional anesthesia acts by reducing this response. Then there is a sympathetic nervous system which is inhibited following regional anesthesia techniques, which reduces the stress response of the body, and followingly the catecholamine which is released are also reduced. Then regional anesthesia also provides an immunomodulatory effect, which reduces the pro-inflammatory cytokines which is produced in the body. So the critical appraisal of the journal. Pros: a large sample size was used for this meta-analysis. A low degree of inconsistency is present among all the trials in our meta-analysis. The population with preoperative cognitive decline was excluded. And the meta-analysis explored multiple exploratory evaluations on the available data. That is the anesthetic method, the invasiveness of regional anesthesia, mode of delivery of local anesthetic post-op, analgesic regimes by various subgroups were all compared. Benefits persisted even after attempts to neutralize the coercitious effect via subgroup analysis. The limitations: delirium can be divided into different types. That is, can be divided into hyperactive, hypoactive, and mixed. So, hypoactive delirium can be missed, and the incidence of delirium is imputed. The effect of additional preventive factors like cognitive exercise on the efficacy of preventive blocks should be better studied. The clinical heterogeneity is high. That is, they have compared different population, different blocks, and anesthesia techniques and the type of surgery. Then the definition and criteria of postoperative cognitive decline is varied among included studies. And there is no report on severity of post-operative cognitive dysfunction and the use of antipsychotic agents for treatment. So in conclusion, supplemental regional anesthesia blocks are beneficial in preventing post-operative cognitive dysfunction in patients after major non-cardiac surgery, and future trials should focus on the high-risk population. Thank you, sir.
Veena, you have conveniently avoided all the statistical part of the article. Isn't it? So what is one take-home message of this article?
So one take-home message will be that regional anesthesia blocks has evidently reduces the post-operative cognitive dysfunction in the geriatric population, sir.
Correct. So IORA classes help, and the IORA program helps.
Yes, sir.
Okay. So regional anesthesia is a supplementation to the whatever anesthetic practice that you do. So you can block any pain in some other way. Okay.
Yes, sir.
So the drawbacks of this study is how was the anesthetic given? That is not very well discussed. How did they monitor the neuromonitoring as such? The level of anesthesia that they provided, there is no talk of the ways they monitored the brain during an anesthetic.
Yes,
so which
sir.
is the main important thing which determines postoperative cognitive dysfunction. If your anesthetic is very deep, your patient is going to wake up with a drowsiness that is evident.
Yes.
Whether you give block or not, that has not been discussed.
Yes, sir.
But rest of the other things are discussed well, saying that in post-operative nausea vomiting is less. Maybe there is not much of changes with the blood loss. Definitely, I agree that it modulates the immune response in the patient
Yes, sir.
if you give a block.
Yes, sir.
Any other inputs, Dr. Arun?
Deepak, I'm driving again.
Okay.
So you just carry on.
Okay, fine. So,
Veena, can you explain the local anesthetic per se effect on the cognitive dysfunction, how it works there?
Yes, sir. The post-operative cognitive dysfunction is mainly caused by sir, there are different techniques by which there is different mechanisms by which it is caused. There is a blood-brain barrier dysfunction which occurs in the following the anesthesia techniques that we use, and that can also lead to the production of inflammatory cytokines. Then there is the microglial cells also produce inflammatory cytokines which can lead to postoperative cognitive dysfunction later. So what does regional anesthesia does is local anesthetic, it decreases the amount of, it causes an immunomodulation, that is it decreases the amount of pro-inflammatory cytokines which include IL-6, IL-8, tumor necrosis factor alpha. All these are decreased by the local anesthetic, and it also modulates, so it modulates the amount of inflammatory cytokines which is produced, which can decrease the post-operative cognitive dysfunction later. And there is another thing is, sir, there is another mechanism in which there is a sympathetic stimulation blockade. So sympathetic stimulation, what it does is it produces increase in heart rate, increase in tachycardia, and all the metabolic events in response to trauma. The body tries to act to the trauma and tries to adjust to the trauma by causing increase in the sympathetic response. So this is avoided in regional anesthesia, especially by a neuraxial anesthesia. It can cause a sympathetic inhibition, which will further decrease the stress response to the body. And as told earlier, it will decrease the, if there is no stress response from the body, there will be a decreased level of cortisol produced, there will be decreased level of adrenaline, noradrenaline produced, and which will help in the proper or better recovery of the patient, especially in the geriatric population. So, hello, sir.
Yeah. Do you use BIS while giving anesthesia at your place?
Sir, do you use BIS?
Bispectral index,
Yes,
or
sir.
some way of neuromonitoring.
Sir, we do use BIS in our institution, sir. It depends on the type of surgery we go through, sir. Surgery we are going for, like being in a orthopedic hospital, sir, in scoliotic patients, when we use BIS, sir, for scoliosis surgeries.
Yeah, what is the BIS that you target?
So 40 to 60 is the BIS that we target for general anesthesia, sir.
Okay. So majority of the times, if you happen to see, if you see burst suppressions which happen during induction and maintenance, so that is something which will increase your post-operative cognitive dysfunction.
Oh, okay.
You have to try to avoid getting into that burst suppression mode.
Okay,
whichever anesthetic or whichever way that you anesthetize the patient, you have to keep that in mind.
Okay, sir.
Veena, coming back to this article, did they did not use a particular include a particular group of patients,
Yes,
which
sir.
are meant. Which one was that? Which is meant to be the highest risk?
So the patients who are having already like a cognitive dysfunction, sir. The geriatric people who are having cognitive dysfunction or who have higher risk, which they feel that which have got higher risk of producing cognitive dysfunction, they've not included that people, sir. But sir, if that is included, then our local if our local anesthesia or the regional anesthesia will be effective in the other population, we won't be able to study, right, sir?
But
Hello, sir?
but that is the group which you would actually want the least
Yes, sir.
the group where you want to upset things the least, isn't it?
Yes, sir.
Okay. And in terms of any other limitations,
Yes, sir.
any other limitations of this RCT?
Sir,
What, any other limitations in the RCT on the way the groups were included or what was included or not included?
sir,
Antipsychotic use?
sir, antipsychotic use, sir. Those people who have used antipsychotic, they've not included, sir.
Or was it not included, or just some of them reported, some of them didn't report it?
Sir, that is, sir, that was, sir, after developing a post-operative cognitive dysfunction, if they have used an antipsychotic, is what they have reported, sir. So
Yeah, pre-op,
Pre-op,
they
they
have
have
not
not discussed.
reported, or
no,
not all
sir,
of
they
them
have
have
not
reported.
reported. No, not reported, sir.
Yeah, because that again will matter, isn't it?
Yes, sir. So I think they've tried to exclude that group so that they just wanted to concentrate like how a regional anesthesia is just beneficial for otherwise more prone patients, sir, geriatric population. Or hello, sir.
Yeah. I think we have summed it up. Yeah.
I'm driving, so I might go out in between.
Yes.
Yeah. Carry. No.
Yeah.
Yes, sir.
Okay. Nice presentation. Yep. So if there are no questions, probably we can sum it up. Yep.
Anybody else has got any questions?